It is just a huge honor for me today to be podcast interviewing Dr. Reid Pullen, DDS, FAGD. Graduated from University of Southern California School of Dentistry in '99. He then completed a one-year AEGD, Advanced Education in General Dentistry program in the Army Dental Corps in 2000. He served 3 years in Landstuhl, Germany in the U.S. Army. Thank you for serving. And then practiced as a general dentist for 2 years in Yorba Linda, California. I assume that's a suburb of LA or San Diego or?
Yeah, it's in Orange County.
Orange County. We got a lot of international viewers, so Orange County would be LA.
Yeah, it's between Los Angeles and San Diego, right in the middle, right on the coast.
So Dr. Pullen attended the Long Beach Veterans Administration endodontic program and graduated in 2006. He opened a private practice limited to endodontics in Brea, California in 2007 and became board certified in endodontics in 2013. He lives in Yorba Linda with his wonderful wife of 23 years and has 2 teenage girls and a 20-year-old boy. His hobbies include speaking, surfing, Brazilian Jiu-jitsu, reading, and golf. He loves, he fights in some tournaments and does worry about getting injured and not being able to practice. But Jiu-Jitsu does help feed his soul and calm him down. He loves to go on Christian dental missionary trips to Haiti and even went to Liberia a year and a half ago for 2 weeks. He takes one or both of his daughters on these trips, and it helps them see the real world and get out of Orange County. His 20-year-old son is yet to go. He typically extracts teeth, but last year he purchased a portable dental unit and performed some simple restorations. He is always looking for dentists interested in going down with him. There is only a 35% chance you'll be kidnapped and murdered. In Liberia, he met one of the worst landlords, at least back in the Liberian Civil War, General Butt Naked. He is the character that is the bad guy in the musical Book of Mormon, except that they say he is from Uganda. He is currently creating an online continuing education course for Dental Town. And my gosh, I asked you to come on the show. You didn't ask me. I wanted to get you on the show so bad. I love your website, and I love the pictures. I'm trying to think of you got a couple websites. Is it the Root Canal Academy?
Right, Root Canal Academy.
You have a picture on your Root Canal. When I first saw it, I said, I'm going to steal this picture, but I thought before I steal it, I better at least get to meet you. But it's a picture of a dock going out into the ocean, and the dock branches out kind of like a root canal would. Do you know what I'm talking about?
Yes. It's not a great picture.
Oh my gosh. What is that on? What is that on? Is that your, is that on the Root Canal Academy website?
Yes, it's on Root Canal Academy, and I actually put it in all of my lectures too, because it kind of shows what the end of a root looks like, and all the different, extra anatomy that you'll see at the root apex, the deltas, the apical deltas, the anastomoses, those little extra canals in there, the lateral canals and accessories. So it's kind of a cool picture to
I'm still not finding it. Is it on the About, the FAQ? Where is it on your website? Is it one of the blogs?
Yeah, it may be. It's in. I know it's in my lectures. It might be in the resident membership site, like where you go on. You go into the resident site, and there's a free area, and then there's a resident member site where you pay for the online course. It's the whole 2-day boot camp course is online.
Yeah, well, I got you on the show because the real reason I brought you on the show is because these kids come out of dental school. They've already committed to, on average, $285,000 of other people's money. You're an endodontist. That's a specialist. There's 10 specialties. One of them is public health dentistry. And the public health dentistry people, they don't like it when you go back to a town of 3,000 and you're the only dentist. But you just decided, I don't like endo. And you're like, well, you can't go to the hospital with a broken arm, and they say, well, we don't like arms. If you broke your leg, we'd fix your leg, but we just don't like arms. So from a public health point of view, when you tell, I grew up in Kansas, when you tell someone they got to drive 2 hours to a doctor, well, they're just not going to do it. And then you'll go back and complain that people don't fill their prescriptions or that they're not being compliant. Well, you didn't make it easy and accessible and affordable. And then there's the financial side. You just came out of school with $285,000 student loans. You got to sell veneers. You don't have to sell a toothache. I'm coming in. I hurt. Insurance will pay 80%. Yet Miss $285,000 in student loan says she doesn't like endo, and then she might be the only available public health deal. So my first question to you is, what do you say to a 25-year-old that just got out of A.T. Still University of Mason says, I hate endo?
Well, first of all, I tell them I hated endo too. I hated endo. And when I was a general dentist in the military and then even in private practice, I was awful at doing root canals. And that's one of the reasons I love to teach. I have a passion for teaching these young general dentists how to do root canals more, effectively and more efficiently. So I would tell them, you've got to have a playbook. You have to have a plan when you start your root canal process. So I think dental school kind of gives us the base, that gives us sort of the background, but you have to continue your learning. And that's why we have, websites like Root Canal Academy of online learning, but also there's a lot of different 2-day courses out there, 1 and 2-day courses. I do like a 2-day root camp, boot camp, and I teach a playbook, a root canal playbook. And that's my whole, I played football in college. And so I call it the 4 quarters of the root canal game.
What position did you play?
I was a receiver, and then I gained so much weight. I was up to 220. They moved me to a tight end. So I was a tight end. And so I was getting too big. So I had to,
Who was Terry Bradshaw's receiver when he got 4 Super Bowl rings? Who was his?
Lynn Swan.
Lynn Swan. Oh my God. I grew up in the most handsome quarterback was bald. And no matter what he threw, Lynn Swan would catch. But so you were a receiver, and so how do you get from 4 quarters of a football game to a root canal?
So what I did is I created a process. I mean, it's called the 4 quarters of the root canal game, and it's a whole playbook. And I actually have a 120-page playbook online, and I hand it out on all my courses. And so what it is you have 4 quarters of the root canal game. You have to follow this playbook all through the game in order to win the root canal game. So for instance, the pregame is accurate diagnosis, does the tooth need a root canal, and then case selection. Can you do the root canal as a general dentist? Is it a simple case or a medium case? Yes, then the general dentist can do it. Or is it a hard case where you have to refer it out? So that's the pregame, and then the first quarter of the root canal game is the anesthetic, adequately anesthetizing the patient.
So wait, first quarter is diagnosis.
Pre-game is the actual pre-game. You're going to go out on the field and stretch, and that's accurate diagnosis. And then you're going to look at, once you diagnose the tooth, yes, it needs a root canal. And then you look at the tooth, and the second thing is case selection. Can I do it? Can I do the root canal? Do I feel comfortable doing that? And my whole goal is I want to teach general dentists how to do the simple and medium difficult root canals, and then to refer the hard ones out, the calcified cases, the long curvy canals, the sexy anatomy, the sexy roots that are long and curvy. So to get those out of your office if you can. But then you move to the first quarter. If you feel like, hey, I can treat this case, how do you numb the patient? We under anesthetize patients. We got to anesthetize the patient so they're completely numb. And then we go on putting a rubber dam. So then the first quarter is just anesthetize and then putting the rubber dam on. And I go through a whole series of what clamps you use, how do you put the rubber dam on? My whole goal is to put the rubber dam on in 30 seconds or less. And then you want to teach your assistants how to put the rubber dam on in 30 seconds or less. And then I move into, do you want me to go through all the quarters? Is that
whatever so first quarter is anesthetize.
Yes. And
anesthetize and rubber dam.
Yep. That's the first quarter.
Well, you know what I did? When I opened my practice in 1987, when I put it my first operatory, I took a rubber dam and I stapled it to the ceiling above me so I could practice under rubber dam the rest of my life.
Nice. It's perfect, man.
It was the only one I ever placed, and it's been there for 32 years. No, I'm just kidding. But I do have that on the ceiling just so I can always say that as a joke. But anyway, so first quarter, anesthetize and place rubber dam.
Right. Then you move to the second quarter of the root canal game. And to me, this is the most important quarter of the whole game. This is where you score a couple touchdowns and you start to win the game. And that's access, finding all the canals, then once you find the canals, you have to do a coronal negotiation, then you do a coronal flare, which opens up the orifice. Once you've done that, then you can negotiate down to patency, which I think is the most important part of the whole root canal process, is just negotiating down the entire root to patency, which is going out 0.5 millimeter past the foramen and into the periradicular tissue. So once you can do that, you can get an accurate working length, and then you can get a nice open glide path. And that's the second quarter of the root canal game, the hardest part. And that's where you set yourself up for success. And I always say score a couple touchdowns in the second quarter. Then you go into, and you don't need to worry about the third quarter, which is shaping. You shape with your NiTi files. And I think once you have an open glide path, the shaping today with the rotary files out there, the NiTi files, it's pretty simple. The companies have created amazing files that just don't break. They're hard to break now. So now the third quarter, you're shaping. It's pretty easy because you have an open glide path. And then the fourth quarter of the root canal game is filling, obturation. And you can do that through a single cone with bioceramic sealer, or you could do, my favorite is a warm vertical obturation with like Kerr sealer or like AH plus, ThermoSeal plus ribbon sealer. Or you could do like a Gutta-Core, like a carrier fill, like Gutta-Core or Thermofill.
Yeah, I'm gonna get in trouble for saying this, so I'm not gonna I'm gonna blame it on you. I'm gonna say you said it.
I like it.
You know what? But seriously, when I went to UMKC Dental School from 83 to 87, we had 6 full-time endodontists for our little class of 120. Yeah. And now there's some dental schools, I won't mention any names because they're both in Phoenix, Arizona. They're up the street from me, where they have like 1 full-time endodontist for this huge class. And then you run into these kids and they're out of school and they're calling you up about, does this tooth need a root canal? They didn't do any electrical pulp testing. They didn't use ice. And it's like, you just feel like, man, you dropped $400,000 on a degree and you don't even know the basics. So I hate to dumb you down on all this stuff, but a quarter of my listeners are still in dental kindergarten school and the rest are all under 30. So I want you to just go over the first thing you said is I think I'd rather you get an A on diagnosis and a C on the root canal then get an A on the root canal and have the wrong diagnosis. I just want them to get an A on the diagnosis and treatment plan. And then they can be an ABC dentist. I'm sure there's a whole parabola of dentists you can be. But what do they need to do to diagnose? What has to be done to diagnose that this tooth needs a root canal?
Well, the first thing is when the patient comes to my office is I still follow the SOAP note. SOAP, subjective, which is the patient interview, the patient's chief complaint. We have to interview the patient when they sit down. My assistants do that now because they have all the questions. We have to interview the patient and we have to get what is your problem? What is hurting? And we want the patient, I like the patient to point to the tooth. Hey, this tooth right here hurts when I drink cold, or hurts when I bite, or it keeps me up at night. And I want to get a good interview first from the patient. Then what we do is we take a straight PA, and then I do a shift PA X-ray. Then I always like, if it's a molar or premolar, I love taking a bite wing. And a bite wing, I think, gives us so much information. We can look if there's any marginal discrepancy, if there's interproximal caries, obviously. But the other thing with a bite wing is, if you do end up accessing this tooth to do a root canal, a bite wing, sometimes if it doesn't have a crown on it, or even if it does, you can actually see the pulp chamber clearer than a PA. And it can give you information like this tooth has pulp stones in it, or it's calcified, or, whatever. And I think that's where we want to start. We need to get more than just one X-ray. And then secondly, if you have a CBCT, this is a little more specialized. Obviously,
I'm sorry to interrupt you, but was that the subjective objective assessment plan? Did you go through all 4, or are you still on?
So I already went over subjective.
Okay, review subjective one more time. Summarize subjective. Okay.
So the subjective would be the patient interview, their chief complaint. And we ask them questions like, first of all, what hurts the tooth? What's going on? You describe your pain. And we like it when the patients are chatty Cathy, when they just start telling you everything, because sometimes you need that information. There are times when patients, it's almost like they don't want to tell me anything. And I have to draw out what's going on. And I'm like, well, thanks for helping me. That's really great that you're helping me so much. But you have to ask them the right questions. What hurts the tooth? Are you having trouble chewing? Does it hurt to chew? Another question I like to ask is, does it hurt when you're driving or watching TV? Does it just hurt by itself? We call that spontaneous pain. Does it wake you up at night? Are you taking Advil, Tylenol, or medicine for the pain? Have you had a recent restoration? And if you have, how long, when was it done? Just trying to get as much information as you can. A lot of times you can get the answer. You can kind of get the idea of the diagnosis from the patient's chief complaint. If they tell you, I have severe lingering cold pain, they're not going to say lingering pain. They're going to say, I have severe cold pain, and then it hurts for 20 minutes after I drink cold water. Then you know that the tooth is vital, that it's an inflamed pulp. It's irreversible pulpitis, right? And if they say, look, it just aches all the time, I don't think I notice any hot or cold pain, it aches and aches and aches, then I'm thinking it's probably pulp. The pulp is necrotic. So pulp necrosis would be the pulpal diagnosis. So I kind of go, that's where I start from, as a subjective. Then I move to O, the objective part, and there's two parts to that: the radiographic evaluation and then your clinical testing. So the radiographic evaluation in the objective part of the SOAP note is our two PAs, straight and a shift, and then a bite wing. I like to take a bite wing if it's a posterior tooth, again, to see for all the reasons I stated previously. You can look at the pulp chamber clear, you can look for interproximal caries, make sure it's restorable. And then I'll do a CBCT if needed. I take a lot of CBCTs in my office. It just gives me incredible information. In fact, in a case that I'm unsure about, I always say the cone beam, the CBCT, is like God sitting on my shoulder telling me the answer, saying, Reid, look at the lesion. You didn't see the lesion on the PA, but look at that lesion on the palatal root. It's clear as day on the cone beam. And now you know it's the tooth has got a necrotic pulp with a lesion, and you need to do a root canal. So the cone beam helps if you have it. If you don't have it, if you're a newer dentist, I don't expect you guys to have it. So you can still get a quality diagnosis from your radiographic, from your PAs and your bite wing.
What if you were an expert witness at a court case and the judge or the attorney said, is a cone beam a standard of care? Is it the standard of care in endodontics where you are in California? How would you answer that?
I don't think it's the standard of care yet. I'm almost sure that. I don't believe it's the standard of care. We're continually arguing that. Some endodontists are saying we need to take a cone beam on every case. And that, I don't necessarily disagree with that. I'm not sure if I agree. A cone beam always helps you see. In fact, I tell the patient, when I take a cone beam, I can open up the book and look inside, open up the tooth and look inside before I even start accessing. So I know where all the canals are. I know where everything is. Any retreat I do and any surgery I do, I require a cone beam. So maybe it might be standard of care with apicos and possibly with retreatments in the future. But for right now, it's not standard of care. It's just an adjunct to help us with our diagnosis, and I think it's fantastic. But there are plenty of cases I don't take a cone beam. I mean, I just did a couple upper molars yesterday, and I did not take a cone beam. So I had to search, and I found the MB2, but I didn't know a cone beam would have been nice to see, but I just didn't take one because it was a vital tooth, and I knew I'm not going to see any lesions because I tested it with endo ice, and they jumped out of the chair. So it was I know there wasn't going to be anything in the bone, but the CBCT would have helped me find the MB2 and show me where the canals are.
Okay. And then so that was that's subjective, objective. That was objective. So the next.
So now I go to the clinical exam, the second part of the objective part of the SOAP note, the O, the clinical exam. And my whole goal is to do my clinical exam in 30 seconds or less. Okay, so what I do is if they're pointing to tooth number 3, the maxillary right first molar, I will test 2, 3, 4, and 5. So I like to test multiple teeth. I like to start also on a tooth that I presume to be healthy. So if they're pointing to 3 and they're saying that's real sensitive, I always like to start on 2 or 4 or 5. And the reason I do that is I like to get a baseline of the patient. So some of these patients are really touchy. They're real nervous about being in there, and they'll jump as soon as I tap on number 5, even though they're pointing to 3. So I kind of know, look, you got to be careful with your diagnosis here. they're kind of jumping on everything. Everything hurts them. I'll start with percussion. I'll percuss each cuss tip. I'll go 5 to 4 to 3, and then to number 2. And I'll percuss each cuss tip. And I'll, my assistants will write down, is it +2, +3, plus, if there's any pain. Then I'll do a mobility. I'll check probing. Then I'll go to a bite stick, and I'll place the bite stick on each cuss tip. And when they bite down, I actually kind of torque the bite stick up a little bit just to get a little more pressure. So, and I'm marking down any pain, either within normal limits, 1+, 2+, 3+. And then the very last thing I do, and this is what I recommend this, the last thing I do is endo ice, okay? And I use a medium cotton pellet, not a Q-tip, because the Q-tip doesn't hold the cold long enough. The fibers are too tightly bound on the Q-tip. Okay, I learned this in the Army, so from an endodontist. So I do a spray on a medium cotton pellet, and I put it right on the buccal of 2 and 3 and 4, and I get a reading, a baseline of if 2 and 4, they jump, and then 3 is worse, then you kind of sense, okay, well, cold number 3 is way more cold sensitive than 2 and 4.
So you spray endo ice on a cotton pellet, and then with tweezers put it on the buccal?
Yep, exactly. And a lot of dentists, I noticed, they don't even do an endo ice test. So a lot of my referring dentists will call me and they go, I'm not sure if the tooth's necrotic or what's going on, but I'm going to send them over. I was testing them. And I said, well, did you do endo ice? And they always go, no. And some of the guys are still using CO2 snow, the old, which I think is kind of getting pretty rare now. Do you know anyone that uses that at all? Where you got to do the ice, the little pin ice that you do the CO2 snow out of the tanks. Well, I was doing that as a general dentist.
I'm embarrassed to say what I do. I'm so damn old. I take the old lidocaine, Septicane carpules, fill them with water, and put them in the freezer.
Yeah.
And then they give me one of those, and if you just hold it in your hand, it warms up enough where the ice slides out. And then does anybody still do that? Or
I think some people do that. I think the endo ice tends to work better than that because it's colder. And I call it's ice on steroids. I always tell the patient, this is ice on steroids. You're going to feel this. It goes through crowns. It goes through porcelain crowns, PFMs, ceramic crowns. No problem. It might be a tad bit slower, but you account for that. So you're going to account for a PFM, maybe a second slower, but it goes right through them. That's why I like endo ice more than just the regular ice. And the cans are pretty cheap. I think the regular endo ice is like $24. But if you get them from like different companies like Henry Schein or Darby, it ends up being $13 or $11. So for these new guys out that are worried about money, you can buy endo ice for half the price, and so I highly recommend any general dentist that wants an accurate diagnosis to have a bunch of cans of endo ice in your office. It's just easier. I think it's easy to spray it on a cotton pellet and stick it on the buccal of the tooth, versus the ice. So no offense to you, but.
No, but their stress, it seems like the most stress they're having is they know it's on the right side. They might even know it's in the right quadrant, but they don't know which tooth it is. That's a very do you see that problem a lot where people?
All the time. I mean, there was a study out years ago, I can't remember, like in the 70s, that said the patients I can't remember the number, they were wrong 30 or 40% of the time. They go, it's this tooth right here. And it ended up being the tooth behind, number 2 or number 4. It was this completely different tooth. So that's why I want to test a whole quadrant. I like to test, you don't have to go 2 to 8. I go 2 to 5 or 2 to 4, number 2, number 3, number 4, maybe number 5. And I like to get a good baseline, and then you can tell. And sometimes nothing lines up. It just doesn't make sense to me. So if it doesn't make sense, I can't duplicate or replicate the pain they're having from their subjective complaint. If I can't duplicate that, then I am starting to kind of take a step back and go, hold the horsey here. We don't want to start guessing and drilling on a tooth until we have a real clear, accurate diagnosis. Every now and then, Howard, nothing will make sense on the top, and they'll say I'm having severe cold pain, and 2, 3, 4, 5 are fine, and I'll go down to 30 or 31. I'll test the lower quadrant, and every now and then, I mean, it's pretty rare, probably once a year, it'll be referred pain from the lower molar to the top, and they think it's on the top. And again, that's pretty rare, so don't be too worried about that. But if things aren't making sense or lining up, I will go to the lower quadrant just to check it.
But when you do the clinical part of your objective exam, it's mostly cold? Is it percussion? Is it electrical? What is there? Is it always the same battery of tests?
Yeah, I do the same battery. So I follow a whole like oral exam system. I do the same thing. I do percussion first with a mirror, the back end of a mirror, and then a probe, periodontal probe. I have those in my hand. I'll do percussion of each cuss tip. Then I'll take the back ends of each of a metal instrument. I'll check mobility, and then I'll flip over the probe and I'll check my probing of each tooth. And then I'll put the periodontal probe down. I'll use my finger and I'll go and I'll do apical palpation on the buccal, and I'll palpate each area. Usually they don't feel it unless, I'm looking for swelling. I did leave out one part. I always do a clinical visualization. I look at the tooth. I'm looking for cavities or cracks first. I dry the teeth to make sure when you dry it, you'll be able to see cracks a little better. And then the last thing I do is my endo ice. And I save that because I feel like if you do endo ice first, you freeze, and this is totally unscientific. This is just anecdotal in my own 13 years of private practice. I feel like you freeze the nerve. If you do endo ice first and then you do percussion bite stick later, you get altered test results. So that's why I wait till the end to do my, the crown jewel of all the tests, the endo ice spray on the medium cotton pellet.
So that's all your clinical exam that takes less than a minute?
Yes. And I don't do, I'm one of those guys, I just stopped doing EPT, the electric pulp tester. I just would get I don't think.
Is that because you found out you were Scottish and not Nazi Germany?
Right. Is that from Germany? Is that EPTs from Germany?
Yeah, it was from Germany. And the cavet?
Yeah.
That was made in World War II, where during military, scientists make up all kinds of neat stuff. Like the Japanese during World War II, they figured out how to make, they thought they'd lose their source of sugar. So they invented, high fructose corn syrup.
Oh, is that how?
Because their government said, well, if we lose corn, if we lose sugar, we got to learn how to make something else out of sugar. So they had year-long stockpiles of corn. So their scientists made that. The Americans, you were using amphetamines to stay up during war. So the Imperial Japan invented, what's the one they use now? What's the new amphetamine? Crystal methylamphetamine. Because the Americans could stay up 2 days on their standard amphetamine, and Imperial Japan made them stay up 3 to 4 days on crystal methylamphetamine. But the Germans asked for something in the field that if their tooth broke off and needed coverage, so they just said, well, let's make a cement that sets up when it comes in contact with water. So IRM came from World War II, Germans.
And what's fascinating is when I was doing my Army training, I ran across some special forces soldiers, and they were telling me both of them were medics, and they were telling me how they did a whole dental course, and they use cavet, and they're out in the jungles. They know how to take care of teeth. They were telling me all about it, and they knew cavet and everything. And they knew temporary fillings until they get back to a base.
I don't. Those guys are some of the weirdest guys on the planet. I had a guy tell me just this year, and a patient, that in his training on surviving, that of course they switch. You're not gonna eat cows and chicken and lamb and sheep. You're gonna eat insects. That's like beetles. Are a quarter of all the animals on Earth are beetle species, and this guy tells me, he goes, but you know what? I just never learned to like beetles, but I'll tell you what, grasshoppers, I could eat them all day long. And I just thought, oh my God. Then he said, have you ever eaten one? And he said, I know it sounds crazy, but if you eat one, you'll start craving them. And I'm like, I'm pretty sure I'm not going to ever crave to eat a grasshopper alive out of my garden. But anyway, so your exam's only a minute. It's oral examination, it's percussion, perioprobe, mobility, bite stick, then endo ice, and you don't need the EPT. You don't need the electric pulp anymore.
I mean, it's another testing device that gives you information. So it's not a bad thing. I've just found over the last 13 years that I've been able to diagnose most of the teeth just with that testing, that series of testing. The EPT would be good. I mean, I think it could help. Sometimes it gave me some false readings. And so that's kind of why I sort of just put it away. Mike, Howard, if I don't know, if I'm unclear and I'm unsure about a tooth, I do a wait and watch. And I tell the patient, I go, look, do you want me? I don't want to work on the wrong tooth. I have to be sure that I have the right tooth. And I have a bunch of patients like that. Every month I'll have a few patients that I'm just unsure. And I tell them, look, let's reevaluate this in 2 weeks. And if it starts hurting, and then come in sooner and we'll take care of you. So I never leave them out in the dust. But sometimes these patients will take, I just took 600 milligrams of ibuprofen an hour ago. And I'm like, well, son of a bitch, it's like, I wish, they take all these NSAIDs and then you can't figure out, it takes the inflammation of the tooth away. You can't always figure out what the problem is. So I always say, wait and watch. If you're unsure, the tooth's got to be guilty beyond a reasonable doubt before you treat it.
Nice.
So that's kind of the way.
Okay. So then you would be next at, assessment.
Yeah. So my assessment is I'm putting together the subjective, the patient interview, their chief complaint, and then I'm putting that part together with the objective, the diagnosis, the radiographic diagnosis, and the clinical testing. Did I duplicate or replicate their chief complaint, or did I come close to that? Does it make sense? And then I form a diagnosis. And here's the deal with the diagnosis. You have to have, every tooth that you do a root canal on needs to have an inside the tooth diagnosis and an outside the tooth diagnosis. That's the big thing is your diagnosis is your assessment. So you have the SOAP note, the subjective, the S, that's patient's chief complaint. And then you got the objective, the clinical, the radiographic exam, clinical exam. Then you have your A, which is your assessment, which is the diagnosis of the tooth. So if the patient jumped out of the chair with their endo ice, then and let's say they're sensitive to percussion or bite stick, then your pulpal diagnosis is irreversible pulpitis. And itis is just inflammation. So pulpitis, inflammation of the pulp, and it's irreversible. So it's inflamed. So I tell patients, it's like when you sprain your ankle and your ankle swells, it's like you have a sprained tooth and your tissue is swollen inside the tooth, but it has nowhere to go. So it hurts when you drink cold or you use it. And so that's your pulpal diagnosis. And then what's your periapical diagnosis or periradicular? So if you tap on it and it hurts, then we call it symptomatic apical periodontitis. That's the most common periapical diagnosis out there. And that could be with a lesion or without a lesion. It doesn't matter. It's just if they're symptomatic to palpation, percussion, or bite stick, then your outside the tooth diagnosis is symptomatic apical periodontitis. And that's if think about it, if you tap on a tooth, the end of the tooth, the root is actually hitting down on a periapical tissue that's inflamed out there. So it hurts when they bite on it, they're hitting on it. So that's kind of where your diagnosis comes into play. And there's much more different diagnoses. If you have a sinus tract, it's, it'll be pulp necrosis with chronic apical abscess, because the sinus tract, it took a while to work through that cortical plate. And so that's why I call it's chronic. It took a long time. If they're swollen out to here, and then it's going to be the periapical diagnosis will be acute apical abscess, because they're swollen. It's acute. Acute is never good, right? When you're in the hospital, if you're acute, that's bad. So acute apical abscess is the big swelling. So
unless she's a real old lady, like 80 or 90 years old, and if you tell her she has acute gingivitis, she says, well, thank you.
Thank you so much, Howard.
Thank you so much for saying I have acute gingivitis, whatever that is. So you have these 2-day root camps. If you go to rootcanalacademy.com, you teach these 2-day root camps. By the way, this is not a commercial for you or a plug for you. This is there's no money changing hands here. Your next 2-day root camp is January 24th and 25th and April 24th and 25th in Brea, California. My question is, where the hell's Brea, California? And what do you teach on these 2 days at rootcanalacademy.com?
Okay, so Brea, California it's North Orange County. So we're about 20 minutes from the beach. And in my 2-day root camp boot camps, what I do is we start with lecture. So I have about 8 to 10 people in my courses. We do a lot of lecture. So you got to get a good base, got to get that solid base. Then we do a lot of hands-on. So we're doing lecture, a lot of hands-on. We come back, we do a lot of intimate discussion. where the general dentists are going, they're raising their hand, they're asking questions, they're getting all their questions answered. And I'm going through my whole 4 quarters of the root canal game, giving them a playbook. Because I feel like the dental schools, I don't mean to say this negatively, but I just don't feel like when you do 6 or 7 root canals in dental school and you get out, it's really hard to know what the heck you're doing. And I was a complete moron when I was a general dentist trying to do root canals. I had struggled with them. I did not have a playbook. So I'm trying to give all the guys in my class and gals a good solid foundation, a playbook, so they can follow this when they go to their practice. And so what I do, we do this discussion lecture, we do lots of hands-on, and then the final exam is on the second day. I do a live patient molar demo. And so I have a True Vision big screen TV, and it's a 3D TV. So I put the camera in front of the patient's mouth. It's like a microscope, but it's a camera, and it projects onto the TV, the big screen. And then what I do is I'm a puppet. And obviously I access the tooth first. I find the canals, but I go, what do I do? And they walk me through the whole playbook. They tell me how to do it. And this poor patient sits there for 2 hours or an hour and a half, and I do the root canal on them. And I go, what file do you want me to use? And they pick sometimes each canal, we use a different file on each canal. And sometimes we do a different obturation technique on each canal. It depends on the timing and stuff. But the people that come to my course, I customize the course based on what they want, so it's kind of a cool course. I want them to go away to their private practice and feel much more confident that they have a playbook, a system that they can now use when they do their root canals. And they can pick and do the simple and medium hard root canals, and then refer the bastards out, get the hard ones out of there, and then, to an endodontist. And I just want to do one plug. On April 24th and 25th, it's going to be the first ever 2-day root camp, boot camp, surf camp. And Howard, if there's any chance you'd come out for that, we're going to get you up on a surfboard. I'm renting out the Newport Beach Surf School, and we're going to have longboards, soft top longboards with wetsuits, and we're going to do 2 hours of surfing with surf instructors. So my goal is to try to get the people that are from the East Coast or during the winter time, or it's getting spring now, but in April, but that they've always wanted to learn how to surf. And I'm guaranteeing that.
Is that going to be the January course or the April course?
The April course.
Because it'd be too cold in January?
We could actually, in January, it would be better. But because I've never done it yet, I'm trying to figure. I like to do it in January personally because it's cold. And
I will absolutely go to that course because I'm absolutely in love with never going to hotels anymore with the grandkids and doing those Airbnb houses.
Yes. And
California's crazy. You can rent like a 3-story, 5,000 square foot beach home for a couple $100 a night. And I'm always like, are you serious? And the grandkids, it's just so much more fun with the grandkids in a house than in a Marriott with, rooms and, all that weird stuff. So you don't have to twist my pinky far at all to go rent a beach house in Cali.
Yeah, it'd be great. I'd love to have you.
Yeah, we just love it. Back on this endo, I mean, my gosh, if you did 1 molar a week per year, I mean, that's $50,000 of revenue. Their student loans don't cost $50,000. What I don't understand about like your 2-day root canal boot camp, half the dentists aren't doing molar endo, and molar endo. I mean, how much is this course? How much is a 2-day course?
It's $21.97.
Okay, don't even say 21. Say for the price of 2 root canals.
Yeah.
I mean, it's like they don't want to go to Richard Litt's ortho course. They're like, I don't know, it's $4,000. Well, your first ortho case is $6,000. I mean, how do I have to explain this to you? So you hate molar endo, and you go to a course, and it's going to cost you 2 molar root canals. I mean, and it's not even about the economics. It's about when you tell, I mean, come on. At age 65, 10% of Americans have 0 teeth. And at 64, and at 74, 20% of Americans have 0 teeth. Well, you know who's part of that problem? Part of that problem is the dentist. You know, they're rural America. They're a small town. They're 8.5% of America's emergency room visits are odontogenic in origin. You know why? Because the real doctors are open 24 hours a day, 7 days a week. And then Jimbo's open Monday through Thursday, 8 to 5, and doesn't check his messages from Thursday at 5 to 8 in the morning. And that's just no way to run the oral health of a country. I want to go back to specifically where we started. She hates molar endo. You didn't like it when you got out. What do you think it is they hate that they can eventually get over? I mean, what's going on in the journey where you go from, because I understand you're a wrestler. I'm third generation wrestling family, and my boys all wrestled year round from 5 to 15. It was our whole family deal. And when you're 5 and 6 and you're getting pinned on every match, it's no fun. But years later, so where are they getting beat up, and what are they learning to where they finally say, this ain't so bad, to where one day they're like, I like molar endo?
Well, I mean, let's start back. I think with the dental school, and the dental schools, I believe, are doing the best they can, but they don't have the resources or the time sometimes to spend.
You're too kind. You're too kind. They're charging $100,000 a year, and they have one endodontist for 100 kids. And then you look at the not profits, and they have $100 billion in their trust, in their war trust fund. I mean the Harvard and AT still, these guys got trust funds in the billions. So they can afford to give more education for $100,000 a year. You're being way too kind. This is Dentistry Uncensored, and you're being dentistry with kindness. But anyway, but go on.
I usually have no.
You usually
I've
what?
got my filter on. I need to take my filter off. I usually live my life with no filter, which gets me in trouble all the time with my wife. But she goes, you can't say that. So yeah, I think, okay, so the dental school education, they do the best they can, but sometimes it just sucks. I have to be honest, my USC education sucked. My endo education sucked. And I don't want to blame completely on them. It's on me too, but it sucked. When I came out in the Army and then even in private practice, the reason they get beat up is they're lost. I feel like the general dentists are lost when they're doing a root canal. They get stuck. They don't know how to properly negotiate down a canal, which is the most important part, I think, of the root canal, or one of the starting parts where you have to be successful. You've got to get down the root. So these guys and gals come out of dental school. They try to do root canals. They get lost inside the tooth. They can't get down can't get down the canal. They can't get a working length. They kind of throw their hands up and go, what the heck's going on? I'm frustrated. I'm stuck. I perfed or whatever. So my whole goal in dental, in endo education, I have a passion to teach, because I sucked. I felt lost and frustrated. And when I had a sucky, I felt like I needed more education. So that's why I like to try to give them a playbook. So they have a whole playbook to follow. And if they get stuck on negotiating down the route, they have a 10 file. They're stuck. They have RC prep on it. I want them to take it out. I want them to take an 8 file and put a little apical bin with their fingernails. And then I want them to place it down, and I want them to take the 8 file on a walk. Take it on a walk, just like you take your dog on a walk around a cul-de-sac. Take that little 8 file with the apical curve on a walk around the apex and try to find where that curve is. Because a lot of times when you get stuck trying to go down a canal with a file, it's because there's a curve. It's not always tissue or calcification. It's usually the canal's curved. And so sometimes you got to put a little bend on there. You have to use a smaller file like an 8 or a 6, and you got to work it and try to get in there and take the file on a walk and move the little curve around so you can find where it curves. What happens is these dentists, they come out like I did, and they're construction workers. They're hammering nails into the canal, and you got to learn to be a painter. We got to be like Picasso and Rembrandt. We're painters inside the canal. You got to do these gentle brush strokes. You can't be slamming the file down, hammering the file in the canal, and then go, I can't get patent. I can't pop out the foramen, and I can't get down the canal. So that's where I try to, I think there's a lot of good endodontic educators. A lot of my friends are now educating, and I think you have to get to a course. Of course, I think the 2-day boot camp's a good course, but you have to get to a course and you have to do further education.
And I'm going to tell you a couple of my endo tricks, and I want to tell you, and I'm going to see if you agree with them or not. I think cutting an access and looking down that hole into the canals is very, very hard. And look, you cut an access and you're looking in a mirror. But so I prep the final restoration first. So when I get done preparing my tooth for a crown, it's well, first of all, I do it because I don't want to do a root canal on a tooth if you can't restore it. So I want to take out the MOD, the last crown, the decay. I want to do my whole final restoration, and then when I cut the access, it's now the tooth is already 2 millimeters plus shorter, and I just seem like I can just see everything so much easier by prepping the final restoration before I do my access. Do you think that's
brilliant?
I think brilliant.
Yeah, well, you've made it a lot easier on yourself. Like you said, you've cut down your working length by a couple millimeters, and it's much easier to do that.
And if you just have an access hole in a tooth, you might have 3 files in there. One be 24, the other one being 22, the other one being 20, because you got all these custom grooves. Mm-hmm. But when your crown prep is completely done and you packed your cord, and then you cut your access and put in 3 or 4 files, they're all the same length.
Yeah, that's brilliant. Yeah, I don't have that luxury because I'm not doing crown preps, but I think as a general dentist, 100% yes.
So I'm going to ask you another question, because some of my friends and I debate about this, but I think I'm right and they're wrong because I know I've had more beers than they have. I believe that if a tooth has a crown on it, and say the crown it's 5 years old or more, mm-hmm. and this tooth died, doesn't that mean something's leaking under the crown? I mean, so when they drill through the top and do a root canal, I'm like, in my 32 years, when you take off that crown, you almost always find the source of decay, infection, something. I mean, do you just have a tooth? I mean, if a tooth is completely contained and just dies, it's dead. But when it's infected, where did those bacteria come from? I mean, it either came out of the bloodstream and went up into the tooth, which is very not going to happen, or that crown was leaking somewhere. So if that crown's leaking, doing a root canal through a 5-year-old crown, I don't get it.
Yeah, I think I agree. You have arguments for both. So you could have a tooth that had a large filling. So then you have a tooth, the nerve was starting to die anyway, but you put the crown on, it's not leaking, let's say, but the nerve was already starting to die and get the bacteria in from the leaking filling, and you took, 5 years ago, you took that filling out, put the new restoration, then to put a crown on top. So that's one avenue that the bacteria could have been introduced a while back, and the pulp's fighting that whole 5 years, and then finally it dies. The other avenue, I think, is you have leakage. So I think in a system, I mean, you have to go case by case, but yeah, in a perfect world, if it was socialist medicine, you would take the crown off every time and look for leakage if you could do that. I think if you have a boutique kind of dental practice where you could say, look, I just don't feel right about this crown, let's do a new crown. I think most patients will say, yes, let's do it. But it just depends on the patient.
So it could really be argued either way.
I do think yes. Yes, but I agree with what you're saying. If there's any doubt that there's leakage, then do a new crown.
Okay, here's the other question they're always posted on Dental Town. The tooth's hot. They did everything you said. The tooth needs a root canal. They go in there, they take out the MOD amalgam, and there's a black line underneath the amalgam, and they freeze. But what do you do when you see a black line? How does that change what you're doing, or doesn't what do you do when you see that black line on the floor underneath an MOD amalgam?
First thing I do is I explore the fracture. So they're already hot tooth. So no matter what, I'm gonna do at least do a pulpotomy or pulpectomy. So what I tell the patient, once I take out the amalgam and I see this mesial distal fracture line, the first thing I do is take pictures under the microscope. I take a couple pictures, so I have it stored in their chart. Then I'll go down. I'll go ahead and access the pulp chamber. Okay, so let's say it's usually it's either necrotic or hot, inflamed, just depends. And I'll kind of start cleaning out the pulp chamber. Once I get all that tissue out of there and I get it clean, then I can look at those mesial and distal crack lines, and I can see how far they go down the tooth. Do they stop just at the pulpal floor, or do they extend into canals? And so that's when I have to make a final decision. Is this tooth cracked? Is it a vertical root fracture? And is it going to, if I do a root canal and you put a crown on it, how long is it going to last? So then we'll have the discussion with the patient. But if the cracks stop at the pulpal floor, I take pictures of the cracks and I tell the patient, look, our goal now is to save this tooth for as long as we can. There's a cracks on both sides. I don't know how long it's going to last. I don't know if the crack's going to propagate down the root, but it needs a crown. We have to finish the root canal and do a crown. And so usually the patient's under the rubber dam and they kind of shake their head and go, okay. So there's a little bit of gray area with fractures and cracks. They're very difficult to decide when, what to do. If you see the crack go all the way down the canal, let's say it's usually number 31, number 18, the mandibular second molars are the most common ones to fracture. And it's that distal marginal, that distal marginal.
Which ones are the most likely to fracture?
18 and 31, the mandibular second molars. And it's usually that distal marginal ridge fracture line. And that's where I see that all the time. If it runs down into the distal canal, 5 millimeters that I could see, then you're really, 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 you're kind of gambling if you do the root canal.
So your concern fracture isn't on the floor underneath the restoration. It's on the distal marginal ridge of the second molars where they would bite the most. And you're talking about a vertical up and down fracture?
Well, I'm concerned about both. I skipped around a little bit. Let me go back to the mesial distal marginal. If that fracture, I take out the amalgam and I access the pulp chamber and I see the fracture go across the pulpal floor, then I'm thinking I'll do a pulpotomy or pulpectomy to get him out of pain, put calcium hydroxide in there, and then I'll refer him back to the dentist or the oral surgeon, whatever they want to have the tooth removed.
If you take out the pulp and the black line is on the floor underneath that, the prognosis is bad.
Very bad, yeah. Poor, very poor. So that's where I kind of scratch it there. But it's the ones that are a little more questionable where it's more of a gray area. And I think cracks are the biggest bane of endodontics because we can't help that. Like you see a fracture or crack that goes down the marginal ridge, it's usually marginal ridges. It does not across the pulpal floor, but if it goes into the canals, then you're really playing with fire. So sometimes if it goes kind of into a canal real clear, I'll recommend extraction. Other times I'll tell the patient, look, we're this one's very questionable. It's very guarded. Our goal is to try to keep this tooth for as long as possible. And the patients know. I show them the fracture. I show them the pictures of the crack that I took under the microscope. And I tell them, I educate them. Because every patient thinks a root canal is 100% successful every time. So I always tell patients this, regular root canals are 80 to 90% successful.
Well, the relationship, if you work at Chick-fil-A, you're good friends with the people who sell you meat, buns, bread. I mean, your whole value chain goes to Christmas parties together. But when you're in dentistry, like you're out in California, the California Dental Association meeting every year in Anaheim, San Fran, they've never thought to ask like the CEO of Delta Dental of California who sells $1 billion worth of insurance. The dentists have treated them so toxic that there's almost no relationship in the value chain in dentistry, especially with insurance companies. But when you're me and you're lecturing to a group of dental insurance executives like in Florida, they'll show you their data, but they won't let me publish it on Dental Town or post it on Dental Town or whatever. But they show me that when you look at like 100 million root canals done, if an endodontist does them in 5 years, 5% are extracted. And if a general dentist does it in 5 years, 10% have extracted. What do you think is the difference between endodontists, 5% of their molars being extracted in 5 years versus general dentist, 10% being extracted in 5 years?
Well, I think there's a lot of variables, but the first variable, I'll say upper molar, it'll be missed MB2.
For the endodontist or the general dentist?
For the general dentist. So
but you're an endodontist.
Right.
So let's start with you before me. You're an endodontist. Why do you think 5% of endodontist molars, endos, are extracted in 5 years? What do you think their bane is?
I always blame two things. I always blame the general dentist, the coronal restoration, and a crack. No, that's a joke. That's a joke. I don't. That's
it's okay because every crown that I've ever done that didn't fit, it was the lab man's fault. It was
Right.
never, ever, ever my fault. Just don't ask any of my, just don't ask. But anyway, what do you think the endodontist or, why do you think they're 5% failed?
Well, I mean, I think it's just part of the game of we think it's clean. We do the same procedure every time. We use our same files. We follow our playbook. We think the canal's clean, and there might be a little bit of tissue at the end. Let's just take out the chance that we miss canals. Let's just take out all the anomalies that we miss canals. I think a lot of it is that maybe there's a little tissue at the end. There's so much complex anatomy that maybe there's just a little bit of tissue causing inflammation and causing a lesion. Or there's a crack. There could be a crack. I mean, the joke in if you're an endodontist, if the patient comes back, you did the root canal and they're having pain, you always say it must be cracked. And that's the big joke. Well, you have to have evidence that it's cracked, before you say, let's take the tooth out. So,
and a CBCT isn't going to show you that crack in 2020, right?
Not necessarily. It'll show you the bone loss surrounding the crack. If it's been long enough, you'll see a vertical bone loss that runs along the crack. And so that's kind of the indicator that possibly that's going on. But I'll be honest, I think sometimes it's just complex anatomy. That's why I think irrigation, the disinfection protocols have to be better. And we're getting close with, I use something called Gentle Wave. I've used PIPS, which Rico DeVito, right out of Scottsdale, it invented PIPS from the Photona laser, which is photon-induced photoacoustic streaming, which is like laser disinfection.
What's the website on that? PIPS?
PIPS, yeah, it's called PIPS, PIPS, and it's photon-induced photoacoustic streaming. And that's from a laser from Lightwalker or Photona. They have like a tip that you put into the bleach inside the access, and you run it, and it causes these thousands and thousands of microbubbles to form, and then the microbubbles collapse. And when they collapse, they form a sonic boom effect. And it helps to clean out the tissue and clean out all those intricate anatomy, those anastomoses, the isthmuses, the apical deltas. But I think even better than that is the new Gentle Wave. Have you heard of Gentle Wave at all?
Is Gentle Wave from Son Endo?
Yeah.
Okay,
yeah.
So Son Endo is the company and Gentle Wave is the product.
Is the product, yes.
Yeah, but that's a chunk of change. What does that cost right now?
About $70,000.
How much?
$70,000.
$70,000. So you got to do 2 root canals to pay for your course, and you got to do 70 root canals for this. Right. So I can see an endodontist 70. Sure. How long does it take an endodontist to do 70 root canals? A month?
Yeah, I mean, fairly quick. If you're doing 6 a day, let's say 4 days a week, that's 24. Yeah, I mean,
6 a day.
Yeah, let's say 6.
Almost every old endodontist. I mean, someone that's my age. I'm 57. My older endodontists say that the biggest change they've done in their 30 years is they've gone from doing 5 to 6 molars a day to 4 to 5 molars a day. They all the other ones say that all the cleaning, shaping, all the high tech. It's kind of like a kitchen. It's like they invented the dishwasher, the blender, all these utensils. But my mom says that now it takes longer to cook dinner than it did when she didn't have any of those things. And I thought that was funny when mom told me that, because my endodontist told me the same thing. Everything they bought from instant digital radiography or whatever, it seems like they now do a molar less a day, because before they had any of that stuff, they always did every tooth in under an hour. Yeah. But now they got microscopes and all this stuff like that. And now they're more like an hour and a half a molar.
Sure.
Or do you agree with that or disagree? Or
I somewhat agree, because I think you see more. When you have a microscope, now you see what you're missing. Like if you can't, I always say you got to be able to see inside the black hole. When you're working inside the access, if you don't have any type of loops or a microscope, it looks like a black hole to me.
So this Son Endo makes the Gentle Wave $70,000 ultra cool cleaner. Tell them how it works. And did you buy it? Did it sell you?
Yeah, I bought it, and it's a kick-ass device. I mean, it's the best thing I've ever seen to clean out canals. I mean, I'll look inside. From what I can see,
I thought I was looking at the best thing to clean out a canal. While I sit home and drink a beer while you do it. Oh, okay. So other than an endodontist like you doing it, this is the best one to clean it, huh?
Yeah, I mean, it's best I've seen, and I think they're, I'll look inside on a lower molar, the mesial canals, and I've just cleaned out the mesial canals, and you can do minimal shaping, and it'll clean out all of the isthmus tissue between the MB and the ML canal of a lower molar. It'll uncover the MB2 on an upper molar. And so it's a pretty killer device. I understand it's expensive, and so it's not always realistic. So let's talk about this. So Howard, what's the next best thing for a general dentist that's right out of school for an activated irrigation or disinfection versus like a PIPS laser? It's expensive. A gentle wave's expensive. I think the next best thing, I call it the poor man's PIPS, is the endo activator from Dentsply Sirona. The endo activator, did you know that? It's got a polymer tip, like a little plastic polymer tip, and it gives you sonic vibration. So what I say is I call the bleach inside the canals, I call it bleach piranhas. You want to get the bleach piranhas, you want to get piranhas in there as soon as possible to eat the microbes and eat the tissue. And you want to stir up the bleach piranhas inside the canals using your endo activator, which is a sonic activation device with a polymer tip on it. That's $400. So yes, I think there's the best thing you could use is gentle wave.
Are you doing an online CE course, or are you doing for Dental Town, or are you doing an article?
Yeah, I'm doing both. I have an article coming out November issue of Dental Town on warm vertical obturation or warm vertical condensation, whatever. And then I'm doing an online course, if I can not be lazy and get it done, on warm vertical obturation, the technique of doing warm vertical.
Now, are you in that course, are you gonna cover Son Endo's gentle wave?
In my 2-day boot camp, you mean?
Or on the online CE course?
No, because I think it's too complex. I mean, that's a whole separate part. That would be your final disinfection.
Do you know Joe Dovkin?
Uh-huh. Yeah.
Remember him?
Yeah, he passed away. Yeah, I use his pluggers, the Dovkin pluggers.
Yeah, he was, we were roommates at Creighton University. We were both on the 9th floor of Swanson Hall. I was 915. I think he was 924. And his brother, John Dovkin, was down floor. And so was on the 8th floor was the congressman who's now a senator, or the dentist who's now a congressman from Flagstaff, Arizona.
I don't know.
Kyle, what's his name? What's the, oh my God, I'm drawing a blank. I can't believe him. Dentist, Congress, Paul Gosar. Sorry, Paul, if I forgot your name. But yeah, Dovkin was responsible for about getting 4 or 5 of us into dental school. I mean, he was your personal tutor for chemistry, calculus, physics, all that kind of stuff. But he loved the warm gutta percha. He just loved it. He called them squirters, and he was not into cold gutta percha. He liked the warm gutta percha. And he also divided every endodontist. There's only 2 types of endodontists in the world. Either you're an apical barbarian and you love to get a puff of sealer out the apex, or you were this pulp lover guy who wanted to stay a ½ millimeter from the apex, and he really didn't even want to meet you or shake your hand. So I have to ask you on behalf of Joe Dovkin, thank you, Joe, for what you did to so many dentists. But are you a pulp lover or an apical barbarian?
God bless you, Joe. But I would say I am more of a apical barbarian before. I don't go a millimeter short back. I like to go to the foramen, and I use my apex locator, my electronic apex locator. Where that tells me, I'll go. So I'm usually right close to working length. If you take a film, my fill is right at close to the radiographic apex. I don't like the giant puff daddies. I like little puff babies. I want a puff baby, not a puff daddy.
Yeah, but if you don't make any puff and you're a pulp lover, don't you think you should just find something other to do than endo? I mean, maybe go be a surfboard instructor for the rest of your life, or
right.
Or something like that.
Clean. Not that you have to have a puff, but I just like to feel the little baby puffs are nice because you feel like you've cleaned the entire canal. That apical red zone is clean. At least you feel like it's clean. So
yeah, that is
daddies, no puff daddies. The big giant puffs of sealer. You have one on Dental Town that we call it Puff Baby. Have you seen Puff Baby? It's bioceramic sealer. Someone injected it out, and it went all the way out the apex, and it looks like a baby tethered to the umbilical cord. And It is the best picture I've ever seen. I don't know if it's photoshopped or not.
Well, talk about that. I mean, I don't like to talk about obturation necessarily because my endo training was by oh my Bambi Duro Oguntepe from Lagos, Nigeria, Africa, who then went to practice in Gainesville, Florida with his wife Cammie, who's a lawyer, and I was her babysitter through dental school for their three kids, Deji Boy, Falaka, and Coco. And Bambi used to say 1,000 times, if you find all the canals and get them all cleaned out, Howard, I don't care if you fill it with bird shit as long as it's sterile. And then you get out of school and no one wants to talk about finding all the canals, cleaning and shaping. They just get to, well, do you use Thermofill? What sealer do you use? What, you know? So if you come up to me and you got 5 questions on obturation, you kind of missed endo. And that's why I like to, you know, starting to find all the canals, get them shaped, you know, do all that stuff. But yeah, if you did everything right and you're going to obturate, is there anything special with these new ceramic sealers, or is the old Grossman cement still good enough, or where are you at with all these?
I actually think, like you said, Howard, before, it's extremely important how we shape and disinfect the canals. That's extremely important. I think that's number one. We got to find the canals. We got to negotiate the canals. We've got to clean and shape the canals. I do believe, though, that obturation is extremely important. And what I did was from 2004 to 2012, I did warm vertical obturation. So I did the heat, you know, I placed the cone in, I used the heat tip to go down, you know, and try to go within 5 millimeters of, I'd leave a 5 millimeter apical plug of gutta percha because the heat would travel the 5 millimeters. And then I would use a Dovkin plugger. I love the Dovkin pluggers. And I'd push down on that gutta percha and it would mold into the foramen. And you'd have a little thin sealer of like Thermoseal Plus ribbon sealer, which is AH Plus, or Kerr sealer. Those are the two that I use forever, which Kerr sealer is just like Grossman sealer, you know, or Roth sealer. It's kind of similar sealers, the one that smells like cloves. Or you have the resin sealer like AH Plus. And those sealers just, they set, they always set, they work. And from 2004 to 2012, I did that. And things worked. So then in 2012, I decided I'm going to start using single cone with these new sealers. So I started using single cone with like a bioceramic sealer, like BC Sealer, which is an MTA-like sealer. It's a calcium silicate. And these sealers now, they serve not just as a sealer. They also serve as a filler. Like a gutta percha cone is a filler. So traditionally, you just want a little bit of sealer with the gutta percha cone to seal the cone from the outside world, from the periapex, from periradicular tissue. Now you've got this BC sealer, you can squirt in there and put a cone in and do single cone and get this hydraulic condensation, and you could be done in like seconds. And the sealer isn't just a sealer, but it's a filler. Is that kind of clear? So I thought that makes a lot of sense. It's biocompatible, the tissue likes it, it's MTA-like. So I started using it. And I'm just going to tell you my opinion, because it's uncensored. I had more problems. Some worked, but I had problems with post-operative pain. I had cases that weren't always healing or failing. And I don't always necessarily blame the sealer. But here's the problem with some of the sealers, those bioceramic sealers. There is a setting problem, in my opinion. They don't always set. And I believe there's a solubility problem. If you look at the research, some of these sealers are 10% to 20% more soluble than like AH Plus. So the reason I found this out was I had to retreat some of these cases with BC Sealer, bioceramic sealers. And I was able to easily retreat these cases. I had no problem removing the sealers and the gutta percha cones. Okay, so one of the biggest problems, if these sealers set up like MTA, if they really set, you shouldn't be able to retreat it that well. I mean, you can retreat it where the cone is, but then if the sealer's past the cone, it's going to be hard to get that sealer out, right? Well, I was always able to retreat these cases, no problem. And when I did surgery on these filling cases, it looked like when I was under the microscope that the sealer was just mushy, it wasn't always set. So I have gone back to using warm vertical obturation, using Thermoseal Plus ribbon sealer, which is like AH Plus, it's a resin sealer, or Kerr EWT, and I do warm vertical obturation. I no longer do single cone, and guess what? Anecdotally, anecdotally, I have back to my old self where I have healing. I have most of my cases are working. I have very few failures now. I have failures too, of course. Don't get me wrong, but I just don't have as many failures anymore. I get all my recalls back. Things are healing. Sometimes even in 3 months, I'm seeing healing. I had a case yesterday where it was healing in 3 months, a lesion. That's insane. Of course, that's gentle wave. We're starting to see that now. We're seeing quicker healing with gentle wave. But I feel like the old sealers, the traditional tried and true sealers, they set every time. You can throw those sealers on a wall, the Kerr sealer, ribbon sealer, and they always set. Sometimes with the bioceramic sealers and like BioRoot or bioceramic sealers, BC sealer, I'm not sure if it always sets. I think it does sometimes, but I think sometimes it doesn't.
Huh. That was very, very interesting. I'm gonna God, I went over. I hope you can I ask you some overtime questions?
Oh yeah. Sorry if I talk too much. I get excited.
No. You are a true teacher at heart. I think you miss your calling in life as being a teacher, because now you're writing case learning books. You're calling them the learning lessons. There's going to be like 10 or 12 of them in a series. The first book shows regular root canal treatment through highly magnified pictures through the microscope, CBCT images, traditional radiographs, and each case tells a story and has a learning lesson. The second book shows simple retreatment all through. To talk about your books and why are you reading writing these books and what's going on?
So I have two playbooks. I have two playbooks about 100 to 120 pages long on root canal playbook, and then I have a simple retreatment playbook that I've written. So there you have your playbook. But then I decided to do these 10 learning lessons, and what they are, they're just they're like case-based lessons. And each case has a learning lesson, a case focus. So I think in the first book, I may have 25 cases. And I talk about through each case, I talk about how, different tips and tricks to give the reading dentist some pearls. But each one has a focus. One of them's focused on cleaning, like shaping. Another case is focused on what do you do? How do you place calcium hydroxide? And then how do you remove calcium hydroxide when it's a second appointment? What's the playbook? What's your prescription of how do you remove calcium hydroxide? And so that's like each case has a focus. So I have a simple root canal learning lesson book. I have a simple retreatment learning lesson book. And then the one I like the most is all of my mistakes that I've made over the last 13 years in private practice, or the mistakes that I've seen from other dentists that have referred to me, and my mistakes. I put them all in a book, and each case has a mistake. And how did I recover? Or did I recover? And some of them are pretty funny. I've got some profanity in the books. It's a fun book. It's got personality to it, but you also can learn from it because you have these pictures from the microscope. You have the CBCT slices that are kind of molded, in with the pictures, and you have x-rays of pre-op, post-op, and then I'll take pictures of a separated file. I have a case in my mistakes learning lesson where I separated a file and what did I do? Did I get it out or not? And so I think it'll help dentists that are, out in the trenches doing else, and they make a mistake and they go to case 5 and they go, okay, he made the same mistake. What do I do? So that was my goal. And I have those 3 are almost done. I have 2 more in the works right now, and I've got so I'll have 10 probably in the next year or so. 10 of these learning lesson books. It's like a series.
That is going to be really, really cool. Last but not least, if you had to pick a dentist doing molar endo, he could either get a CBCT or a microscope. I know St. Louis makes a microscope. Germany makes a microscope. But how do you, if you can only pick what, a CBCT or a microscope? Which one would you get and why?
Well, if the guy, I would do microscope. But here's the deal, Howard. You don't have to. The next best thing. What's the next best thing to a microscope? They could get the high-powered loops with the light source, because what you can see, you can treat. And they can then have the money to buy the CBCT.
What's the one in St. Louis? The microscope in St. Louis. That's a
Well, you've got Global, Zeiss,
Global out of St. Louis, which is about half the price of the German one. And would you just say it was
the Zeiss Pro
Zeiss, which by the way, Zeiss, it completely changed my boy's hunting. And another dentist friend of mine, I gave a pair for Chris one year. The Zeiss microscopes for hunting. Yeah. I mean, it's you're out there because all hunting, fishing, they all move at sunrise and dark. Like when people say, I always snack before I go to bed. Sorry, but that's what all of biology does for billions of years. I mean, they're not, fish aren't biting in the middle of the day, and all the animals, they all move around, drink water, and eat at sunrise and sunset. That's how Mother Nature works. So you're out there with those Zeiss microscopes, and the sun's not going to break for another 10, 20 minutes, and you can already see like everything. I mean, it's crazy. But it seems like you're only looking at about maybe 8x. So do you got to drop $25,000 to see 8 times larger? I mean, it seems like when you get on eBay, there's a lot cheaper way. I mean, there's people on eBay that can show you how to see 8x for $500, but where do you draw the value line of magnification and how much to spend, and how big a X are you looking at? Are you looking to go 4, 6, 8, 10, 12? Where are you at?
Well, when I work, so I have Zeiss microscopes, the Pro Ergo, which is it looks like the Death Star from Star Wars. It's a big, but it's motorized. It's the best microscope, I think, on the market, but it's also $75,000.
$75,000.
Yeah. So you got to get, Well,
it sounds like a lot of money until you get divorced. Then it's just a rounding error on the L. But anyway, so if you don't get divorced, you can buy all these toys. You can buy everything.
But just hung on too.
You what?
I'm just hanging on now. I recommend, look, I don't sit up there when I lecture and say, you have to get a microscope or you can't do endo. I have some friends that do that, and I go, no, don't do that, because 70% of the general dentists do our endo, 70 to 75, right? Or endodontists are only doing 30% of the endo in this country. So my recommendation is get the high-powered loops, maybe 3.5 to 4.5, and get the light source, the bright light. That to me is going to help you see what you can see. I don't think I think a microscope would be awesome. It's a luxury. You could find them for 10, 15, 20 grand. And there's good ones out. There's new ones out there's a new company out that's pretty good. I can't remember the name. But you can find them if you want to do it.
Magnification.
Yeah, but I think you could use the loops, high-powered loops with light source. And I think and then you could spend your money on a cone beam. And you have the best of both worlds.
Yeah. So I think the miner's light is the way to go, because my problem is I have the overhead light, but I have, which is on a track, and then that's running into the TV mounted. And it's like half the time, what I don't understand my Obtuary is when I reach up to grab my light, where my monkey Neanderthal hand lands on my light, my thumb turns it off.
Oh, right.
Because their best idea is that you would want, when you're hanging on the light, for your thumb to touch the button, turn it off or off. But no, I mean, I just leave the damn light on all day. I'm doing dentistry. I go to move my light and I turn off the light. And then when I turn to my handpiece cart, well, when you grab any high speed or slow speed, you have to lift up, right? Mm-hmm. Well, they're all disconnects. So I should be able to grab my high speed or slow speed and pull it straight out, but they won't let me do that. I got to lift up. Well, if I lift up half the time, I just took off my high speed or slow speed. I'm like, have they ever thought that maybe if you're going to sell dental equipment, that maybe one dentist should try it first? I mean, just one. So that the first time he grabbed the high speed, say, oh, well, he just took it off.
Right.
And I'm just sitting here cussing under my breath thinking, why am I the only person who tried this dental equipment before you designed and made and manufactured it? But yeah, you got to get the overhead light, because the dental manufacturers who are born somewhere between Pluto and Uranus will put the on-off button right where you grab the overhead light. And the high speed, what I do is when I'm not using the high speed, I just loop it around. I just loop it onto the tray table, or I loop it around this load, because you can't put the damn thing back in, because whoever designed it wasn't smart enough to realize that the direction of taking off the high speed is the same direction of using the high speed. Yeah. Well, you know the direction you pull it to take it off? Yeah, that's the direction that you'll need to pull on it to use it. It's like, okay, so obviously no one tried your dental equipment one time before you sold it. So you get the light hat thing, and that just gets rid of all the button things. But I swear to God, if I ever found the guy who actually invented my high speed, slow speed, and my overhead light, I wish I was like you and knew jiu-jitsu, because if I did, I would take him out back and beat the crap. I got to end on that. We're at an hour and a half. Why do you do jiu-jitsu? Because can I tell you the story of I don't know if you can see that, but can you see that bump there?
Okay, yeah.
So
oh no, from wrestling.
No, but I broke my hand the first 4 weeks out of school, and I always look at you guys doing jiu-jitsu and think, well, do you ever worry that you're gonna break a hand and then that's the end of your at least 3 or 4 months of work? I mean, what are you thinking when you're in a jiu-jitsu match?
Well, I'm nervous about that. In fact, right now I can't shake hands too hard, so people will shake my hand and it sends a shot of pain up my arm, because about 2 months ago, the guy rolled on my hand. I worry about it, but I tell you, Howard, my soul, it just gives me, it kind of chills me out. You know, I think have an aggressive personality, and I go to jiu-jitsu and we'll kind of fight a little bit in a friendly forum, you know, and I've done, you know, I do tournaments. The tournaments are scary, because the tournaments, you know, arm bars, and if they catch your arm, they're going to get you to tap. They're not going to be gentle. Like when we go to right now, I go to my class later on tonight, they'll be gentle. I got tapped out a few nights ago. I made a mistake, and I was mad at myself. He got an arm bar on me, but he did it gentle. He ripped my hand, but he didn't break my elbow like this. He was gentle. But in the tournament, you better tap fast. They're hyperextending your arm, or they're doing foot locks. I get foot locks sometimes. But yeah, it's stupid. It's really stupid to do. But yeah, it's just one of those things. I don't know. My wife just shakes her head. But I come home with black eyes sometimes. Like my face is kind of hit, you know, marked up a little bit. I don't know. It makes me kind of, I don't know. I just like it. It just makes me feel, feeds my soul a little bit, you know. But maybe I should pick another art. Let's just go surfing, right?
So your next course is on, if you go to Root Canal Academy. Good job getting that name. I mean, I can't even believe you were able to get that name.
I was shocked.
You think you could get that? You would think that name was, I mean, I started buying website domain names in 1994, and everything was taken back then. I was lucky to get Dental Town. But good job on getting that. So if you go to rootcanalacademy.com, your next courses are January 24th and 25th in Brea, California, and April 24th and 25th. I know they're all thinking only one question. How far is that from Disneyland?
20 minutes.
20 minutes,
That's the best thing. Bring your family. Stay down by Disneyland or by the beach. That's what a lot of guys do, and families. They bring their families. The kids go to Disneyland, and then you got to go to the root camp, boot camp. But we make it fun. We have a good time. We joke, we laugh. I mean, I try to be entertaining. I talk about the warlords that I meet. I met the deadliest warlord ever in Liberia. You know, it's like crazy stuff like that. I talk about that. And,
do you know John Lees out there?
No, I don't. John Lees? No.
Lies? He's an endodontist in LA.
Okay.
Look him up. We went from 7th grade all the way to end of dental school together.
Oh, that's cool. I'll look him up.
But only about, we have determined only 1% of dentists can teach. The rest are so worried that they're going to say something and someone's going to disagree or whatever. What you find, I mean, and we have 250,000 dentists on Dental Town. 1% of dentists do all the original content. 9% just engage, like ask a question, follow up, LOL. 90% won't say squat. And when I ask my friends, like, well, why don't you give a course on that? I mean, it's so frightening. I mean, to stand up there in front of they say public speaking is the number one fear. No one debates that. I mean, it's the number one, even though every funeral I've been to, no one's ever said, well, at least he's not giving a speech. I mean, I'd rather be in the casket than giving a speech. But why do you think 99% can't do public speaking? They can't teach, and you're a natural at this. Why do you love it? And 90% could never consider it. I mean, even when you give a course, does anybody have any questions? No. Okay, well, let's take a break. And then everybody runs up and asks you the question. It's like, I just asked you a minute. You can't even raise your hand and ask a question in front of. So what is your personality disorder that allows you to love to teach and not be living in fear?
Well, I have to be honest with you. I was deathly afraid of public speaking. When I was in high school, there was a time I actually broke down when I was speaking. I had a little presentation in honors English. I was a junior. Here I'm playing football and baseball and basketball. And I actually could not get the words out of my mouth. My chest expanded, and my friends were looking at me. It was a group oral presentation, and they're like, what the, what's going on? It made me fearful forevermore to speak. So what cured me was I like to do things that make me uncomfortable. I like to do jiu-jitsu tournaments. It makes me very uncomfortable to fight. It makes me uncomfortable to speak. It makes me uncomfortable to go to Port-au-Prince, Haiti. When I put myself out of that comfort zone, then great things happen. So I've taught myself to not be fearful. I was so afraid the first time I gave a lecture in Las Vegas. If you were there, I mean, I feel like I did a good job. I practiced the lecture. It was an hour and a half, 30 to 40 times before I went up to speak it. I had it fully memorized, but I was able to speak it where it wasn't memorized. But my biggest key is if you're going to lecture, this is dangerous, put your laptop in your car and drive to work and have a little clicker. I put it in my hand and I click and you look, and then I drive and I practice speaking my lecture. People don't practice. They spend all their time creating their lecture. They spend 90% creation, 10% practice. Then they get up there and they suck because they never talk through the words. So I'll spend 50% creating my lecture and 50% practicing it. You got to practice, and it'll make you way more comfortable. So, and my dad was a professor, and my dad was a public speaker. He gives speeches all the time. So I grew up watching him do that, so.
And what I recommend is, there's an app. I have it on my phone. I don't know where it is. It's Airbnb. And there it is, Airbnb. It's this little red weird triangle thing. And when you're going to a course like that, and he's 20 minutes from Disneyland, and he's close to the beach, and you got your kids or grandkids, my God, that Airbnb app shows the houses so good, so cool, so clear. It's cheaper. It's just like being at home. I just love it. But I love everything you're doing, and it's just an honor, Reid, that you would want to come on the show today and talk to my homies for an hour and a half about the endodontics. Thank you so much. It's Reid, endodontist, Reid Pullen, DDS, founder, Root Canal Academy in Brea, California. Go to his courses. You need to do it for public health. It is absolutely embarrassing that my homies are responsible for 8.5% of all emergency room visits in the United States because they got an odontogenic origin and they can't get you on the phone. And in fact, I shouldn't end on this, but I believe in teledentistry because I tell my patients when they call me evenings or weekends, I say, well, FaceTime me. Oh, I'm not. I'm on Droid. Well, that's not my problem. Go find a smart person that has an iPhone and then FaceTime me because I want to see the tooth.
Yeah.
And my pharmacist in Ahwatukee, they have my FaceTime number. They use and someone will ask them, what do you recommend, whatever, and they'll FaceTime me, and that guy's standing there, showing his tooth. It's teledentistry, buddy, and but you need to be accessible. And if you just say, I'm unavailable to return a phone call till Monday morning at 8:00, and I don't do endo. Well, you know what? You're just being a little brat. And it's time to put on your big boy pants and learn to do molar endo. And if anything, you could teach them how to get them comfortable until they see someone else, right?
Yeah, do a pulpotomy or pulpectomy.
Yeah. So just do it. If you don't like molar endo, well, I'm sure in the last they say 99% of modern humans lived in the last 50,000 years, and it's about 105,000 humans have lived and died, and there's 8,000 alive today. And I'll tell you, when you say you don't like molar endo, think of how many lives did their job. They lived, they reproduced, they had children, they died, they had long lives. How many times did they spend the whole winter in a cave eating nothing but mastodon poop? And a lot of people did a lot of things they didn't like to do so that we could be alive today in the present. So if you tell me you don't want to do something because you don't like it, well, that's not how we got here. Man up, suck it up, buttercup. They got a toothache, insurance paying 80%. If you can't do the molar endo, just put your license in a shredder and let's put some dentist in there that can be a public health accessible dentist. Thank you so much for coming on the show today.
Thank you, Howard. We're going to have a beer together one of these days, right?
I'll go Airbnb in a house during that course. Absolutely.
I would love you to come to the course.
Absolutely.
We'll no question. Get up on the surfboard, I promise it.
Well, I wouldn't even care if I got up there. I just want to see if you can get one of my grandbabies up there. That's.
Hey, they're in.
All right, let's do it.
Okay, Howard. Thank you so much.
Have a great day.